Hi, in today's lesson, we are going to look at dilated cardiomyopathy. And so, in dilated cardiomyopathy, there is a characteristic dilatation of one or both ventricles and is usually accompanied by systolic dysfunction. However, the left ventricle is frequently affected than the right ventricle. And in addition to the chamber dilatation of the left ventricle, the ventricular wall is often abnormally thinned out like a balloon. And we also find that systolic failure is more prominent than diastolic failure. Now, there is impaired systolic function because the ventricles cannot contract enough to push its content, that's the blood, out of it. There is no problem with diastolic function because the heart can easily dilate to receive the blood. So the main challenge is systolic dysfunction and failure, and I will explain this shortly. But before that, we must know that this condition occurs in between 20 and 40 people per 100,000 live births, and males are mostly affected in a ratio of 2:1. We also find it most common among Afro-Caribbeans, and the age group which are mostly affected is between 20 and 30 years of age. Now, dilated cardiomyopathy is one of the most common reasons for requiring a heart transplant. So, when we look at the diagram on our right, what we see is that this heart has a dilated left ventricle, which is bulging out, as you can see over here. And as the cavity increases in size, we realize that the walls also become so thinned out. So you can compare the walls of the left ventricles to the walls of the right ventricles. And you can see that the left ventricular walls are thinned out. So they are weak, they look thin, and they look floppy. And so they cannot contract. So this is the main problem that we find in dilated cardiomyopathy. So what causes dilated cardiomyopathy? Now we realize that when primary and secondary causes have been eliminated, 50% of the cause of dilated cardiomyopathy is idiopathic, meaning we don't know what actually caused it. We have 25% being inherited as autosomal dominant, where we have a variety of single gene mutations which have been identified. There are also some autosomal recessive X-linked, especially the Duchenne's and Baker's muscular dystrophy, as well as some mitochondrial inheritance patterns. Another cause of dilated cardiomyopathy is alcohol. So, chronic alcohol consumption is implicated in the development of dilated cardiomyopathy. And though the exact pathogenesis isn't known, we know that ethanol interferes with oxidative phosphorylation as well as fatty acid oxidation, leading to cellular dysfunction of the heart muscles. And so it is for this reason that we must always rule out alcohol as a factor, because alcohol related cardiomyopathy is potentially reversible, And so reducing alcohol consumption may show a dramatic improvement in the ventricular function of such patients, though this may vary between individuals. Another cause of dilated cardiomyopathy that we know is toxins, and specifically cocaine has been implicated. And so these are toxic to the heart muscles and they may cause dilated cardiomyopathy. Then we have infective and non-infective causes of dilated cardiomyopathies. And amongst the infective ones, the most common ones that we know is the Coxsackie A and B virus, as well as the HIV virus. There are others, including the parvovirus, the cytomegalovirus, and others, but these are the simple and the common ones. Among the non-viral causes, we have the Chagas disease, which is caused by the Trypanosoma cruzi, mostly endemic in Southern America. Then we have others, including hypothyroidism in pregnancy, and so in pregnancy we may have it as postpartum, dilated cardiomyopathy. Then also the use of some chemotherapeutic medications in the treatment of cancer. Example may include doxorubicin and trastuzumab. These are toxic to the heart muscles. Then also malnutrition has been implicated, specifically thiamine deficiencies seen in beriberi. And so a very simple way of remembering the most important causes of dilated cardiomyopathy is what I have given as IMAC CCTV. And the I stands for idiopathic, M for malnutrition, alcohol, C for chemotherapy, cocaine, and Coxsackie. Then we also have the Chagas, toxins, and viruses. So these are the main causes of dilated cardiomyopathy. Now, let's go ahead and look at the pathogenesis of dilated cardiomyopathy. Now, looking at the diagram on our left, this diagram, we find that the heart muscles over here are normal. We don't see any abnormality in it. And so this being the left atrium and here being the left ventricle, the blood leaves the left ventricle through the aorta to the rest of circulation during systole. When we compare this diagram to the right, the one on our right, we realize that the left ventricle is ballooned. As we can see, it's bulging out, and so the walls have become so thin. Now, this problem with dilated cardiomyopathy usually affects all four chambers. However, we usually see that the left ventricle is mostly affected. Now, this dilatation is associated with decreased contractile function, and it shows a decreased contractile function because it loses its strength, it loses its power of contracting to push the blood because it has become thinned out. Now, the impaired function here means that the ventricles cannot contract well to push out its blood. And as the dilatation occurs and the heart chambers functionally get impaired, what the body does is it tries or it attempts to compensate with two main mechanisms. The first mechanism is through the Frank-Starling's mechanism, where an increased diastolic volume will lead to an increased myocardial stretch. And so when the myocardium stretches enough because of its increased volume, then it is believed that when it contracts, it is able to contract with some force to be able to eject the content of the left ventricle through the aorta into the rest of circulation. Another mechanism which is employed by the body is the sympathetic changes as well as upregulation of the renin-angiotensin system. Now, when this happens, it leads to an increase in the heart rate as well as increased contractility. Now, all of these, effects, though they are positive, are limited, and so they eventually fail, causing a vicious cycle of remolding and scarring of the left ventricle. Now, as we've seen, a decreased left ventricular contractility due to the dilatation will lead to a left-sided heart failure and eventually to a right-sided heart failure. How does this occur? I will explain to you. Now, with the left-sided heart failure, as we can see, there is a decreased left ventricular output. So, because the left ventricle cannot contract well to eject its content out. And this usually manifests as a reduced systemic perfusion, because the blood is not going, and so vital organs of the body are not receiving enough blood. And such vital organs may include the kidneys and the brain. And so it may lead to their dysfunctions, as well as you may find cold extremities in these patients. Now, since the left ventricle can't empty its contents properly, there is also backflow of the blood into the left atrium. And so, since there is enough blood inside the left ventricle all the time, anytime the left ventricle empties, anytime the left atrium empties its content into the left ventricle, there is a backflow of the blood back into this section of the heart, which is the left atrium, which also further flows back into the lungs, causing pulmonary congestion. And with this, it leads to an impairment in gaseous exchange. And with time, what happens is that the fluid then leaks from the vessels into the alveolar tissues, which will cause dyspnea, as well as autopnea and symptoms of cardiac asthma. So this is the problem when it comes to the left-sided heart failure. Now, with the right-sided heart failure, what happens is that due to the increased pressure within the pulmonary circulation, as we've seen, there is now built up pressure inside the lungs, which reflects inside the pulmonary artery. And so there is built up pressure within the pulmonary circulation. And so the right ventricular output becomes decreased. The blood is supposed to leave the right ventricle here through the pulmonary artery to the lungs. Because there is pressure within the lungs, the output of the right ventricle also decreases. And so there is also backflow of blood into the right atrium over here. Since the blood cannot leave the right ventricle to the pulmonary artery, then to the lungs, it backflows into the right atrium over here. And when this happens, it also causes congestion in the venous system. And so there is venous congestion with the resultant ascites, because the fluid will leave the vessels into the tissue. Then we may also have some peripheral edema. It may also even lead to some hepatosplenomegaly, and a whole lot of symptoms may ensue. So this is basically what actually happens with dilated cardiomyopathy. Now, I've already explained enough, but let's quickly go over the clinical manifestation of dilated cardiomyopathy in relation to the pathogenesis that I've just explained. So we may have symptoms of heart failure, basically seeing it as shortness of breath, peripheral edema, fatigue, and syncope. Now, the breathlessness or the shortness of breath is due to the pulmonary congestion. The peripheral edema is due to the leakage of fluid into the tissues, and they may show fatigue as well as syncope. Then the patient may also have chest pains, and the chest pains is obviously due to the fact that the myocardium is poorly perfused, because little blood leaves the left ventricle to the entire circulation, and so the coronary arteries also receive very little blood to supply the heart. Then there may also be arrhythmias, such as atrial fibrillation, as well as some conduction abnormalities. And so you may also find some form of bundle branch blocks. Then there may be thromboembolism, and this thromboembolism will ensue because the blood has become stagnant in the left ventricle. And so as it moves, it forms clots, which may go into circulation. This is why we get thromboembolism. And so on physical examination, what we usually see is that there is a displaced heartbeat secondary to the left ventricular dilation. Then we may also see, or hear S3 and S4 gallop when we auscultate. Now, after this, how do we go ahead to investigate dilated cardiomyopathy? As part of our investigation, when we are taking the history, we must pay attention to past coronary artery diseases, chronic alcoholism, or even pregnancy, because we saw that these are some risk factors that may cause dilated cardiomyopathy. And so with our um, with our investigations, The first line of action that we must take is the echocardiography, as we saw in the general description of cardiomyopathy. We said echocardiography is the first best diagnostic step, and it's actually the gold standard in the diagnosis of dilated cardiomyopathy. It shows as a decreased ejection fraction, wall motion abnormalities, as well as dilatation of the cavity of the left ventricle. We may also use speckle tracking, and speckle tracking will show us decreased strain in all directions, as well as a decreased ventricular twist. We may also go in for the ECG, and as we explained earlier on, the symptoms or the manifestations of dilated cardiomyopathy is that of a heart failure, and so we employ ECG and other ones or other methods to help us rule out certain forms of heart damage. So the ECG, when we do in dilated cardiomyopathy, will show a left ventricular hypertrophy as well as a biatrial enlargement. We may also find some conduction abnormalities such as left bundle branch block as well as AV blocks. Then we may also see some QRS voltage, reduction in the QRS voltage. With a chest X-ray, we may find cardiomegaly, and as we saw in the general description, we may also find heart failure. And so, with our heart failure, we know the chest X-ray specific symptoms, the A, B, C, D. Then we can also employ blood analysis, and in blood analysis, we may find elevated ferritin as well as we have to look for the B-type natriuretic peptide, and when we check this and it is elevated, then it may be pointing towards heart failure because it is elevated. BNP is usually elevated in heart failure, and so it will give us a guide as to what we are dealing with. Now we can also look or test for the troponin as well as the CKMB to help us rule out other causes of cardiac damage such as myocardial infarction. Now, these are the first line diagnostic investigations that we can carry out. In our second line, we can do the cardiac biopsy, which is not so much agreed upon by some literatures. Then we can also use the MRI in our investigation of dilated cardiomyopathy. Now, after seeing how to diagnose or investigate dilated cardiomyopathy, let's look at some specific echocardiography as well as chest X-ray signs of dilated cardiomyopathy. And so in this diagram, this is a normal echo showing the ventricles which are not dilated. And as you can see that the walls are nicely appearing with the valves over here. And you can see, so this being the left ventricle, the right ventricle, then we have our atrium also over here, and you can see there is no abnormality detected in the walls as well as in the chambers. Now, when we compare this to A and B over here, what we find is that there is dilatation of the left ventricle in A, as you can see. So the chamber is so much dilated when you compare it to the chamber over here. And as you can see, the walls are getting thinned out like a balloon. And you can see in this diagram, we can see that there is slight atrial enlargement as well. When we compare it to the B, when we look at the B as well, you can see that there is enlargement of the left ventricle over here as compared to the right ventricle. And as you can see, we also find that the left atrium also looks slightly enlarged. Now, when we look at the normal chest X-ray over here, we see that it depicts, beautiful lung markings as well as a normal sized heart, this being the diaphragm. we have our heart over here. And so you see that everything is normal, everything is nice over here. The lungs are well aerated. When we compare this to the B, we find that the moment you see this diagram, the first thing that comes to your mind is there is cardiomegaly. So as you can see, the heart is abnormally enlarged. So it is ballooned out and it has become thin, as you can see in this diagram. And you can see that the lung markings are actually becoming more visible, and they are getting infiltrated with fluid, as may be seen in heart failure. And so this may indicate a dilated cardiomyopathy. Now, let's quickly look at some ECG signs of dilated cardiomyopathy. When we look at this ECG, what we find is that there is marked left ventricular hypertrophy with repolarization abnormality, which is seen as left ventricular strain pattern. And you can see this in precordial lead 5 as well as precordial lead 6. We can also see that there are some signs of left atrial enlargement. And so we see that there is leftward deviation of the P wave, and we can also, in standard lead 1, and we can also find inverted P wave in standard lead 3 as well as AVF, as you can find over here. And so a right axis deviation in the presence of left ventricular hypertrophy suggests that there is what? Biventricular enlargement. And so we used the Sokolow-Lyon test to rule out that there is left ventricular hypertrophy. And with the Sokolow-Lyon test, what we do is we take the S wave in V1 over here, then we take the R wave in either V5 or V6, the one which is longer, and it must be equal to 35. Any number which is more than 35 indicates that there is left ventricular hypertrophy. And so we can count it. Let's pick V5 over here. We start counting from here. And so we have how many boxes? 1, 2, 3, 4, 5, 6, 7. So 7.5 is 35. Now, when we add it to the S wave in V5, we have 35 already in V1. So we have 40, 45, 50. And so we are getting more than 35. And this indicates that there is left ventricular hypertrophy. In the second ECG, what do we find? There is evidence of left ventricular hypertrophy with large precordial voltages and left ventricular strain pattern, as we can see in the R waves in standard lead 1 as well as standard lead 2 and V6, as we can find over here. Now, we used this criteria to determine the left ventricular hypertrophy because we saw that the V wave in the S wave in V2 was more than 35. We can count it and see. You have 1, 2, 3, 4, 5, 6, 7, 8. So when we multiply by 5, we are getting more than 35. This indicates that there is left ventricular hypertrophy. Also, what do we see? There are signs of biatrial enlargement in V1 with a peaked initial portion of the P wave, which may indicate that there is biatrial enlargement, or which indicates that there is right atrial enlargement, and it is followed by a deep terminal negative portion of the P wave, which also indicates that there is left atrial enlargement. Now, the changes of right ventricular hypertrophy are marked by the left ventricular, hypertrophy, and as we can see in this ECG, it was found that this patient had 4-chamber dilatation on echocardiography, and so the findings on the ECG, also confirms whatever we found on the echocardiography. Yeah, so that is it. Now, how do we manage dilated cardiomyopathy? Now, we need to treat the symptoms of heart failure. And as we saw earlier, heart failure is treated with AABD. The first A stands for AC inhibitors, the second A stands for ARBs. So you choose either of them, either AC inhibitors or ARBs, then you go for beta blockers as well as diuretics. Now, what we have to do, the AC inhibitors and the ARBs, what they do is that they slow down they reduce the risk of arrhythmias or arrhythmic deaths in these patients, and they also help to decrease the workload on the heart, thereby trying to improve the survival rate. The beta blockers, what they do is that they slow the heart rate. When we give beta blockers, they slow the heart rate and they reduce the blood pressure, thereby controlling the rate at which the heart contracts and helping to eject more blood out of the left ventricle into the systemic circulation. Now, we also need to restrict sodium intake in order to reduce the amount of fluid in circulation. Then we must treat infection if we find one. Then we have to stop alcohol intake, since we said the alcohol cause of cardiomyopathy is reversible. And so when we stop the intake of alcohol, we see drastic improvement in the systolic function of the patient. Then we must also avoid all toxins such as the cocaine. We must avoid all of them. And if the patient is on some chemotherapeutics which are toxic to the heart muscles, then we may have to change these chemotherapeutics to other ones to help this patient. Now, these patients may also benefit from the implantable cardioverter or implantable cardioverter defibrillator, the ICD, as well as the cardiac rate synchronization therapy. It is only suitable for some selected patients, and eventually most patients may have to go for heart transplant. Now, since we saw that there can be stasis of blood in the ventricle leading to thromboembolism, we must prevent such complications, and so we must give anticoagulants when necessary, to prevent the occurrence of thromboembolism. And though this is not routinely done, it is advisable that we stay on a safer side. So we give anticoagulants when necessary, as well as some antiarrhythmics to prevent, complications of atrial fibrillation. Then, when we look at the prognosis of the dilated cardiomyopathy, we see that the 5-year survival rate is estimated at 30%. So, this is all that I have for you on dilated cardiomyopathy. Thank you very much for your attention. Bye bye.